Hello and welcome to another live broadcast with MedStar Health. My name is Kerunne Ketlogetswe. Today is Go Red for Women Day. So it's the perfect time to talk about the prevalence of heart disease in women. Heart disease continues to be the leading cause of death for women in the United States. But surprisingly, women's awareness of heart disease has decreased by approximately 20% over the last decade, primarily among young women. So today I'm joined by cardiologists, Dr. Brian Case, Dr. Estelle Jean, Dr. Kerunne Ketlogetswe, and Dr. Barbara Srichai. Today we'll learn more about how to recognize the risks of heart disease in women, the non-traditional risk factors, and the steps you can take to keep your heart healthy, and more. So stick around. Let us know you're watching. Give us a heart. Let us know that you're watching today. Share this broadcast with your friends and family. And if you have any questions for our experts, you can ask them in the comments. So before we get started, I have lots of questions to ask you all today. Thank you so much for being here. Really appreciate your time. Let's meet our experts. Before we ask our questions, I'm going to start today with Dr. Jean.
Hi, I'm Dr. Jean, and I have an interest in women's heart health and specifically around maternal health and the important link between cardiovascular disease and maternal health outcomes. Thank you for having me today.
Of course. And Dr. Ketlogetswe.
Good afternoon, everyone. Happy Heart Month. My name is Dr. Ketlogetswe. I'm a non-invasive cardiologist. I'm a preventive cardiologist. I have an interest in cardiometabolic health, women's heart disease, and preventive cardiology. Looking forward to our discussion.
Thank you. And Dr. Case.
Good afternoon, everyone. My name is Dr. Brian Case. I'm an interventional cardiologist here at MedStar Heart and Vascular Institute. I have a strong interest in coronary microvascular dysfunction, which we'll certainly talk about in a little bit more detail, but has a higher prevalence in women. So look forward to talking to everyone about it.
Thank you. And Dr. Srichai.
Good afternoon, everyone. My name is Barbara Srichai. I am actually director of the MedStar Women's Heart Health Program here, and I'm a non-invasive cardiologist. My specialty is in advanced cardiovascular imaging, and I cover all things related to women and heart disease and imaging aspects related to that. And so I'm looking forward to our discussions today.
Thank you very much. All right, let's get into our questions. I'm going to start with Dr. Jean. So as we talked about, today is Go Red for Women Day. Heart disease affects both men and women. So why do we focus on women specifically?
Yeah, the focus really has gone to raise awareness that heart disease kills both men and women. In actuality, actually one in three women die from cardiovascular disease, and that includes both heart disease and stroke. And what I do find in my personal practice is that most women don't necessarily think that it's a women's disease, that is more men who die from heart disease and may naturally think that their biggest risk is breast cancer because at a younger age, they see so many of their loved ones, their mothers and sisters being impacted by cancer. But unfortunately, as I stated, the data does show that 1 in 3 women will go on to die from cardiovascular disease. And unfortunately, starting from the age of 20, that 45% of women have some form of cardiovascular disease. But I do want to take a moment to sort of talk about what exactly is heart disease and when we mention that. As I remind my patients, the heart has 4 main components. We have the arteries, the muscle that pumps the blood, the heart valves, and the electrical system. So when we talk about heart disease, it actually includes any one of those conditions. So if someone has told you, for example, you have a heart valve problem, that is considered heart disease.
Thank you very much. So what do women need to know about heart disease?
They need to know that sometimes the symptoms can be different in how it presents. Now, by far, the most common presenting symptom is chest discomfort. So women can experience pressure, tightness, squeezing, but other times the symptoms could be a little bit more subtle. It could be fatigue, shortness of breath with minimal activities, or indigestion. Sometimes it may be pain in the neck or the jaw or the arm pain. And so the key though, if there's something that's different, don't dismiss it. Don't naturally think because you're older and it's not your heart. Because the earlier that we get to the bottom of it and make the correct diagnosis, the better that comes for women.
All right, thank you. Why do women have a higher risk than men for heart disease?
A lot of times it's driven by the fact that many of their risk factors aren't well treated, right? So we do know the important link, for example, between diabetes, how diabetes in women can increase fourfold the risk for heart disease. But, they may not seek medical evaluation and have their diabetes under good control or their blood pressure under good control. And we're seeing, rates of smoking, especially in younger individuals, and they may minimize sort of the impact of smoking on their their risk for heart disease. So a big link is the lack of treatment. And if we're not going to know our numbers and making sure that they're appropriate range, that significantly can increase our risk. And then also women tend to live longer compared to men. And so we do see many of these conditions having longer impact on our blood vessels, which by an important difference is that women, we tend to have smaller hearts and narrower or smaller blood vessels, which then can be more prone to getting clogged up when we have these important risk factors.
All right, thank you. Let's talk about risk factors. You mentioned smoking. What other risk factors are there for heart disease in general?
Yeah, so we think of the in terms of traditional risk factors or non-traditional risk factors. So kind of the things that we think about traditionally, it's high blood pressure, diabetes, smoking, physical inactivity, family history, right? And of course, family history and age are two risk factors that we can't control. But what's been exciting in the field of women and heart disease and studies is that we're actually seeing there are other risk factors that impact us uniquely, specifically around our reproductive years, right? So women, we tend to go through 3 potential major changes hormonally in our lifespan from a reproductive standpoint. So be it our monthly menstrual cycle or our pregnancy and menopause. And we are actually finding that in all these stages, the bodies at times can give us unique clues. So be it if you have non-traditional risk factors such as polycystic ovarian syndrome, or during pregnancy, if you've had sort of an adverse pregnancy outcome, such as high blood pressure or preeclampsia, they can increase your risk, or the timing of menopause, which I know we'll get into into a little bit more detail, but this is why it's important to discuss all of your risk factors and your reproductive year histories with your primary providers so that we can get a better sense of what your true risks are. And we also know that women, unfortunately, do have higher rates of autoimmune diseases, which include lupus, as well as rheumatoid arthritis, that can increase our risk further for developing heart disease. And the important link, lastly, between our stress, our mental health, so depression, stress, are proving to be important risk factors as well for women.
Okay, thank you so much. You talked a lot, there was a lot of risk factors there. Are there certain risk factors that both men and women have, but that seem to affect women at a higher rate?
Yes, 2 critical risk factors include diabetes and smoking. And so if you're a woman and you have either one of these conditions, it's critical that you get them treated accordingly. Of course, if you currently smoke, and that includes any sort of nicotine products that you really do need to smoke, because again, it's partly related to us having smaller blood vessels compared to men. So they're more prone to the chronic stress and inflammation from smoking or diabetes. Other things include family history. So some clinical studies shows that if there's a family history of heart disease, that can impact us more compared to men.
Okay, thank you so much. Let's talk about hormones now. How do hormones affect a woman's risk for heart disease?
Yeah. So as I stated, there are different phases in our life for which it's critical. So let's first talk about pregnancy, right? So kind of think about pregnancy being sort of the window into your future brain and heart health. And what we're finding is that when you fail this first stress test of your life and develop issues such as high blood pressure, diabetes, preeclampsia, if you have a premature birth or a small baby or low birth weight or small for gestational age, we're finding that these women are much higher risk for developing stroke and heart disease later in life. But what's equally concerning, though, is actually it starts sooner, earlier. So we have studies, for example, showing if you do a calcium score, which is an assessment of the hardening of the arteries, we're seeing it in the early 40s and those individuals who have these complications compared to those who have not. And other things such as menopause. The timing of menopause, which is the last 12 months after your last menstrual period, is important as well. So if you have premature menopause before the age of 40, that is also proven to be an important risk factor, because you're essentially losing the benefit of estrogen that we have compared to men. And so we tend to see an earlier presentation of heart disease if you went through menopause before the age of 40. And other things such as polycystic ovarian syndrome, which can be associated with cardiometabolic abnormalities, which can be discussed as well in further detail, but that has been shown to be a risk factor for women.
All right. Thank you so much, Dr. Jean. That was a great introduction to today's discussion and a lot of wonderful information. Dr. Case, I'm going to go to you next so we can talk about coronary microvascular dysfunction. Can you talk about what that is and why does it affect women more than men?
Yeah, absolutely. And again, thank you for having me. When we talk about coronary microvascular dysfunction, what we're specifically talking about is the small blood vessels within the heart. So if we take a step back first, when a patient is having symptoms, chest pain, shortness of breath, fatigue, and a clinician, a cardiologist feels that this might be due to a blockage in the heart, the patient will typically get referred for a left heart catheterization, also known as a coronary angiogram. And when we perform that procedure, what we're looking at is the big blood vessels of the heart, the highways of the heart, the major blood vessels to see if there's blockage there. If there is blockage in one of those big major blood vessels, that's when we can balloon and put a stent in and relieve the blockage. I'm sure you've had family members or neighbors or friends who have gone through this experience. What we've realized recently, specifically for coronary microvascular dysfunction, the very small blood vessels of the heart that are sometimes difficult to see on a typical coronary angiogram can be abnormal, can be diseased, and can also contribute to the typical symptoms that a patient might have if they had a major blockage in one of the big vessels of the heart. And it's important to make this diagnosis because it can impact a patient's quality of life. And then also, if somebody has coronary microvascular dysfunction and it's not properly identified, it does put them in a potential increased risk for future cardiovascular events, such as risk for a heart attack, risk for a stroke, or other cardiac issues. It does predominantly impact women. There's research that suggests that it impacts about 60% of the time it's seen in women versus men who have been diagnosed with coronary microvascular dysfunction. Why does it affect women more? We don't fully know. There are a lot of theories out there, and there is evidence to suggest that hormonal changes does have an impact on women and impacts the higher prevalence of coronary microvascular dysfunction, because it is typically seen in younger women, but we don't fully know, and there is ongoing research to answer that specific question. But we do know it's important diagnosis to be made, and certainly more prevalent in women.
Thank you very much for that overview. How prevalent is coronary microvascular dysfunction?
Yeah, absolutely. If you look at all the patients that get referred for a heart catheterization in the world that have angina or an angina equivalent symptom like shortness of breath or fatigue, we're talking about 100 to 110 million patients. Of those patients, when they get an angiogram done, 2/3 of the time, we do not find a blockage in one of those major blood vessels of the heart. So that's crazy. 2/3 of the time, a patient is having symptoms. We do this procedure and we don't have an answer. There's no obvious big blockage in the big vessels of the heart. If you take those 2/3 of patients, roughly 50% of them have coronary microvascular dysfunction. So if you start with 110 million patients, 2/3 don't have a major blockage, and half of them might have coronary microvascular dysfunction. Quick math, we're talking maybe 40, 50 million patients might be suffering from this condition across the world.
Wow. Okay. Thank you so much for that. And what about symptoms? If someone could be going through that, what types of symptoms would they complain about?
Yeah, absolutely. So the symptoms of coronary microvascular dysfunction are the same symptoms that a patient may have with coronary artery disease due to, again, one of the big blood vessels being blocked. So angina and or chest pain is a common symptom, pressure on the chest that might radiate to the left arm. But then also what Dr. Jean was saying, that sometimes the presentation could be quote unquote atypical, but really it's not even atypical. It's just different symptoms. And just like she said, shortness of breath, fatigue, sometimes abdominal pain could all be contributing, could be a manifestation of coronary microvascular dysfunction. The other thing that we commonly see with coronary microvascular dysfunction patients is ongoing symptoms, despite being told in the past that their cardiovascular evaluation was normal. This is very common. So a patient has chest pain, they see a cardiologist, they may do an ultrasound of the heart called an echocardiogram, or they might do a stress test, and that's all normal. And they tell the patient, your testing's normal, the chest pain's probably not from your heart. Then the patient goes to a different provider, same symptoms. They might repeat that same imaging. They might even say, hey, why don't we just do the heart cath? They undergo the heart cath and they're told the big arteries of your heart are normal, nothing to worry about. The chest pain isn't due to your heart. And then they continue to have the chest pain. We see this all the time. That specific patient population, and if you're suffering that kind of patient journey, there's a high likelihood that you might be suffering from coronary microvascular dysfunction. And we have the capabilities at the MedStar Heart and Vascular Institute to objectively make that diagnosis and get you on the correct medications to help relieve the symptoms that you're experiencing.
Thank you. That's a great segue to my next question. How is it diagnosed?
Yeah, absolutely. So in the past, we would sometimes do the coronary angiography. The big blood vessels would be normal. And we would say to the patient, oh, you might have coronary microvascular dysfunction, try this medication. Now there's newer technology out there with the capabilities of objectively making the diagnosis. And we have those capabilities at MedStar Washington Hospital Center with my colleagues, Dr. Haider Hashem and Dr. Itzik Bendor, and then also at MedStar Southern Maryland Hospital with myself. And the way the procedure is performed, it's, again, we perform the heart catheterization or the coronary angiogram. We make sure there's no blockages in the big vessels of the heart. And then we simply put a very small wire down the main artery of the heart. And we do some technical injection of saline down the vessel. Don't worry about it. It's very simple. It's very, very safe. And then we have a technology software that can calculate and gives us a number that tells us if there's the presence of coronary microvascular dysfunction or not. So no more guessing. We can use this simple procedure. It takes about 15 minutes to do the procedure, and we can make a definitive diagnosis.
That is great news. So if you are diagnosed with coronary microvascular dysfunction, how would it be treated? You mentioned medication earlier. That one of the treatment options. Can you go through those?
Yeah, absolutely. So first of all, from what we've learned from landmark clinical research trials, just giving a patient their diagnosis and telling them, you're not crazy. Like you do have a reason for your chest pain. It's coronary microvascular dysfunction. That goes a long way. Patients they have a satisfaction that they know they have a real diagnosis, and that alone is very impactful. once you have the diagnosis of coronary microvascular dysfunction, the management is similar to anybody else that has coronary artery disease. So just like what Dr. Jean said, risk modification with diet, weight loss, avoiding smoking, stress management, and then management of other medical conditions, like making sure the blood pressure is controlled, the cholesterol is controlled, and if you have diabetes, that's under control as well. But then in addition, once we've made a formal diagnosis of coronary microvascular dysfunction, there's specific oral, very common medications that we know are more beneficial over other medications for patients who have coronary microvascular dysfunction. So once we have that objective, true diagnosis, we can get patients on the proper medications that will benefit the most to help relieve their symptoms and to ensure that they don't have any, bad event in the future.
All right. Thank you very much, Dr. Case. That was very informative. Thank you for talking through what coronary microvascular dysfunction is. It was really interesting to hear how it could, a patient could go through all of these different tests, have this chest pain and not get the answers. And the fact that we have the ability to test for the potential that you have coronary microvascular dysfunction and we can give you a diagnosis, that is wonderful news. So thank you.
Absolutely. Yeah, my pleasure.
Okay, I'm going to take a moment to thank our viewers for tuning in and for asking questions. We have received some questions so far, so I do want to talk through those. I'm going to start with Dr. Srichai. We got a question that I'll ask you from Sheila. Thank you, Sheila, for your question. Can you discuss the pros and cons for ablation versus medication? And she said and I don't know what these abbreviations are, SVT, PAC, PVC. So if you could talk through those, when you also have COPD, is what she said. And
okay.
Yeah.
So we've talked a lot about, when we're talking about heart disease, I think most of this hour has been spent on coronary artery disease, microvascular dysfunction. I think our viewer that is asking this question is now kind of talking about other things that Dr. Jean had brought up. It's not just about the heart arteries. It's also about the electrical system, and the electrical system sometimes can cause different heart rhythm abnormalities. So SVT is supraventricular tachycardia. So it's a rapid heartbeat that originates from the upper chambers of the heart. PACs, PVCs, those are just early heartbeats that can occur in either chamber of the heart. And sometimes they can be provoked by stress or by certain types of foods that we eat or caffeine in the diet. And so management we usually start with is to see if you can adjust your lifestyle to kind of reduce these stresses that could be bringing these arrhythmias on. SVT, and I want to distinguish it from another type of arrhythmia that commonly we see as atrial fibrillation and atrial flutter. So SVT is a more, I would say, benign type of arrhythmia compared to atrial fib and atrial flutter. So it's less associated with events such as strokes that we know that atrial fibrillation and atrial flutter are associated with. And we commonly see these types of arrhythmias that we're talking about, SVT, PACs, PVCs, often in our younger population. Treatment, everybody is a little bit different. Some people have one episode and it never comes back, and we just kind of monitor, try and avoid things that might provoke it. Some people, it's predictable. Every time I drink a glass of wine, my heart goes a little bit out of rhythm. So I kind of know to maybe caution when I take that wine or drink that Starbucks coffee. And then some patients, depending on how often it's coming on, we often will start with medications. And so I encourage you to speak first about medications, but not everybody can tolerate medications. And sometimes the medications don't have their full desired effect. And that's when we think about ablation therapies. So it is kind of a cascade that we kind of go through from least invasive to then more invasive. And most of this is related to, how is it affecting your lifestyle, or how is it affecting your heart structure and function? Most of the time, it doesn't have any negative effects on the heart structure and function unless there's something else going on. But and it's more of a lifestyle issue. I can't get anything done because my heart keeps going out of rhythm, and medications, then I can't get any work done because I'm having the side effects from the medications. And then in which case, then yes, ablation would probably be the right therapy.
All right. Thank you so much for that. And thank you, Sheila, for your question. I have another question, two questions actually from Betty. The first one I'm going to ask you, Dr. Case. It's related to coronary microvascular dysfunction. She is asking, does tachycardia lead to coronary microvascular dysfunction?
Yeah, so tachycardia, meaning also known as high heart rate, again, is more of a electrical issue. And you can have tachycardia for a lot of different reasons. You can have a high heart rate just at baseline, or if you're doing extraneous activity, or you could have many different types of arrhythmias, kind of like what Dr. Srichai was talking about. Does tachycardia in and of itself ultimately result in coronary microvascular dysfunction? Typically not, but if you have a high heart rate or an arrhythmia, typically you have comorbidities that has resulted in that high heart rate. And some of those comorbidities or other medical conditions overlap with the ones that we see in coronary microvascular dysfunction as well. So it is possible that you could have a high heart rate and also coronary microvascular dysfunction, but it's less likely that just a high heart rate directly results into developing coronary microvascular dysfunction.
All right. Thank you so much. Appreciate that. Dr. Jean, I'm going to ask you Betty's other question. She's asking, is BHRT good for the heart? I don't know what BHRT is. If you can, do we need that from Betty?
Hormonal replacement therapy.
Hormone replacement.
Okay. Yes.
So hormonal replacement therapy, we sort of have gone back and forth, but the general consensus now is we do not use it for primary prevention, meaning that you have risk factors and we're concerned that you're a higher risk for heart disease, and therefore we will give you estrogen to prevent that. We no longer recommend that treatment intervention. But if you do have debilitating symptoms from menopause that's impacting your quality of life, then it is definitely reasonable to speak with your healthcare team to figure out what is the safest option for you for improvement of quality of life. But it is reasonable to consider in low-risk individuals, so individuals without prior heart attacks or heart disease and with well-controlled risk factors. If you're low risk and under the age of 60, it's not unreasonable to really consider that as a treatment option. But generally the guidelines is no more than 10 years, not to pass the age of 60, as long as your risk profile is acceptable. But of course, everything needs to be individualized and discussed accordingly, and do what we call a shared decision-making so that your quality of life is at front, and we are here to discuss the options to help you feel better while minimizing your long-term risk as it relates to potential heart attacks and stroke from chronic hormonal replacement therapy.
Thank you very much. And thank you for your questions, Betty. We have some more questions we'll get back to from our viewers, but I do want to take a moment to go back to you, Dr. Srichai, and ask you some questions about being an advocate for yourself and the importance of not delaying care. Can you talk about how can women be better advocates for their health, especially their cardiac health?
Absolutely. I think the most important thing is an awareness. And I think Dr. Jean had brought that out. This is why we have a day, the Wear Red Day today, to increase that awareness that heart disease does affect women, more so than breast cancer, and to not blow it off and to take care of yourself. I think women are caregivers, right? We have kids to take care of. We have our families to take care of. We're also often working. And so we often don't think about taking care of our own self. I often say, when you're in the plane and the plane is crashing, you got to help yourself first. Otherwise you can't help everybody else. So it's important from that standpoint, and understanding and recognizing and just being aware of the different ways that heart disease can present is important, so that yourself internally when things aren't quite right, you're not quite yourself. And Dr. Jean and Dr. Case mentioned some of the different types of symptoms that women may present with. I think on top of the kind of symptoms women might present with, although chest discomfort is the more common one, I think it's that women have chest discomfort, but other symptoms as well. So they might have 3 other symptoms: chest discomfort, shortness of breath, some nausea. And so they concentrate on other things because there's no way it can be the heart. But all of that together, and we're seeing that, women often have these other kind of symptoms associated, we call them associated symptoms, and that might be a sign of heart disease. And it's important not to delay that, because time is muscle. When you delay that, things can continue to cascade on, and that's affecting your heart every day. And it's hard to assess that or know that unless you get yourself checked out. So that, I think, being aware and just knowing when things aren't quite right. One of my patients is a very young patient who was a big advocate for herself, and is trying to encourage also young people to be advocates for themselves. You should be able to exercise. Don't say it's just because you haven't had enough sleep and this and that. There's no reason why a young person shouldn't be able to exercise. If you're not able to exercise regularly, make sure there's nothing wrong with your heart, because that should be something that young people should be able to do.
Okay, thank you very much. And thanks for reiterating the importance of not delaying care. As a physician, how do you assess women for heart disease differently than men?
I take into account, as Dr. Jean and Dr. Case had mentioned, some of these other types of symptoms that women may have. And I think women tend to downplay their symptoms because, there's just this thought that it's not the heart. And I've had women tell me, oh, it's not pain. I don't have chest pain. I just have this tightness, and that's not the same thing. And that can't be from the heart. It must be something else. And so I try to bring those symptoms out and just say, oh, well, just, let me know a little bit about that. When does that come on? Just to kind of tease it out a little bit more. Also focus on, what was their reproductive history, because that has a big impact. Do they have a history of polycystic ovarian syndrome? Did they have complications during their pregnancy? Are they perimenopausal? Are they postmenopausal? How old are they? Did their mother go through these conditions as well? Because that will have definitely an effect on whether they have underlying heart disease. And we're talking about coronary disease, but on the flip side, valvular heart disease, I have a lot of patients who have underlying connective tissue disorders that can affect the valves. And so just being super aware that the valves are an important part of your heart, and when they become dysfunctional, that can also lead to symptoms that may be more subtle, and may not be necessarily the chest pain, but they may present with more shortness of breath or fatigue. And it's important to recognize these other risk factors that play a role in evaluating the whole heart.
All right, thank you. And my last question for you is there a bias against women when they're seeking care, whether it be from their family or a caregiver? Or do you find that maybe they're even telling themselves it's just stress or it's just this or that when they're explaining their symptoms? Do you see that happening with women?
I think it was more common previously. I think with the heart campaigns that have been going on and the recognition and of the differences, the sex differences in how men and women present, that it's being incorporated more into the guidelines, that this bias is becoming less so. We're increasing awareness, so women are becoming more advocates for their own cardiovascular health and recognizing their own risk factors. I think one of the other risk factors I maybe forgot to mention was, if you have a history of breast cancer, which everyone's worried about, that in itself, because of the treatments you may get for your breast cancer, also is a risk factor for heart disease going forward. So there probably still is a little bit of a bias there. It's hard for me to take that out of the box because I don't see how I don't see other practices. But here at MedStar, I know we're trying to minimize that bias and make sure that our patients are aware of their risk for heart disease, and that our physicians within the system are aware that women have heart disease as well and have high risk for complications related to their heart disease.
All right, thank you very much. And I think another key takeaway for our viewers is for yourself, not just say it's stress or you're tired. It could be something else. So it's important to see someone who can definitively tell you if there's an issue or not.
I think it's also important when you're seeing someone to not blow it off to them either, because that's what I feel women, when I talk to them, will tell me a little bit, but then they'll be like, but it's just stress. And they'll think it's something else. And I'm like, well, it might be, but you've obviously come here because you are concerned, and I don't want to blow it off.
Yep. And I do actually have one more question for you, because you mentioned cardiovascular guidelines. Can you talk about what cardiovascular guidelines are there that are specific to women?
So within the guidelines that we have for different various heart diseases, they are becoming more aware, cognizant, bringing out more of the sex-specific differences in certain aspects of heart disease. So, for example, we talked about presentation and being aware that men and women may present differently and still have heart disease. The differences in how coronary artery disease and some of the processes that may affect women more than men, such as microvascular dysfunction or coronary spasm, maybe more in the microvasculature, or some of the other things like venous coronary dissection. So that's coming out a little bit more in the guidelines as something to recognize and be aware of. One of the and this is in the American guidelines. And one of the other things that I just happened to review and look into, because I was just curious about, women tend to present a little later in terms of when they get referred for heart interventions, such as on their valves. And it's because of the way the guidelines have been worded. Women's hearts, as was mentioned, are smaller, about a quarter smaller than a male heart. But despite that, the guidelines have absolute cutoff values for when you refer patients. And that's being recognized now that women's hearts are smaller. They may not reach that level. And so when women actually get referred, they tend to have more symptoms. And as a result, after interventions, they tend to not do as well as their male counterparts. So that's being recognized as well. And adjustments are being made to the guidelines on a continual basis to account for these sex-specific differences in heart sizes and presentations.
All right. Thank you so much. Really appreciate it, Dr. Srichai. Dr. Ketlogetswe, I have some questions for you now. Wanted to ask you first, so we talked about this a little bit earlier, just about women are busy. They might discount it to something else, or they might just say they're too busy and they don't have time to go get their heart checked. I know I've said that about doctor's appointments myself. What is your message to women?
My main message to women is that getting evaluated early is important. As a preventive cardiologist, a lot of the work I do is telling people about how many of the things that lead to the conditions that ended them up on Dr. Case's table can be averted, prevented, and it's really important to focus on those things. I think we're all cardiologists because we treat a disease as preventable, right? And there are many things we can do. Women do tend to, as caregivers, being distracted by the things of life, caring for children, caring for parents, busy working lives, can tend to not prioritize taking care of their own health. And I think making people more aware, number one, that heart disease is their leading cause of death. It is the thing that they are most likely to die from, but that is preventable and we can do something about. I'll give you an anecdote from my clinic. Just before Christmas, I had a patient who I had referred for a stress test for very worrisome symptoms, and her stress test was subtly positive, but it was positive. And I sent her, so I said, the next step is for you to have a cardiac catheterization. And she said, can it wait until after the new year? I have to take my husband for this procedure and he's not doing well. And I actually had to convince her that I said, we're actually quite concerned and we'd like to get it done as soon as possible. And she actually had a 99% blockage in her main artery. And she was going to put this off until the new year. And so I think, listening to your physicians and the guidance of sort of shared decision, but also being proactive about things and not waiting if you don't have to.
Wow, that is thanks for sharing that story. I think a lot of women can relate to that, and a great message to listen to your providers and to take it seriously. What about recommendations for reducing risk factors? Can you talk through those? What recommendations do you have for our viewers?
People often get overwhelmed when they're told that they have risk factors or they have conditions that can lead to coronary disease or heart disease. And I always tell people to sort of break things down in chunks, right? And make things a little bit more manageable. For example, if you're overweight and you tell yourself, I need to lose 50 pounds, it's a very overwhelming goal, right? It's something very overwhelming. And I tell people, scale it down. What can I do this week? What can I do this month? And to really work on changing things or modifying their risk factors in small increments. If I have high blood pressure, in addition to taking the medications that my physician has recommended, what things can I do in my diet? What things can I slowly cut out? How can I change the spices I use, the salt that I use? What can I change to try and make it more likely that I can help my blood pressure? If I have high cholesterol, in addition to medications that my doctor may recommend, what can I do with my diet? What things can I substitute out from my diet? How can I have one more plant-based meal? What can I substitute? It's small incremental changes that have a huge impact over the long run. And people can often be very overwhelmed and think, I need to become vegan or 100% plant-based. And I say, can you swap out one meal? Can you swap out one day? What can you do in small incremental that will actually change and build good habits or habits that you can adopt that can become lifelong and heart healthy in the long run?
Those are great recommendations. Thank you. Can you talk about when is the right time for a woman to see their cardiologist? And what advice do you have to proactively begin discussing heart health with your primary care physician?
The right time is always, right? I see patients in my practice who are as young as in their 20s, and I see people in their 90s. So it is not like some things where there is an age appropriate guideline, for example, that says you start mammograms at age 40, you start colonoscopies at age 45. There is no one time that we tell people, and you should check in with your heart doctor at blank age, right? If you have predisposing risk factors for heart disease, it's always a good time to see a cardiologist. If you have symptoms that are concerning for yourself, you should be seeing a cardiologist, because we know the power of prevention. We know that intervening early makes a big difference. And so my favorite patients, I say this all the time to my preventive practice, I'm like, you're my favorite kind of patients, because I know that if we make these changes, we're really making a huge impact and likelihood of reducing your risk that you'll end up on the cath lab table, that you'll need interventions in the future, or at least that we can certainly delay the need for those things.
All right. Thank you very much. So if you're diagnosed with heart disease and you are seeking treatment, can you talk about the is treatment for heart disease different in women than men?
When we're treating heart disease, the therapeutics that we have work for both men and women. I think what we've seen sometimes is that women are often not given the same level of treatment. In other words, that they may have delay to diagnosis, they may not be maximally titrated in a way that men might be, that there can be a bias in how they get treated, and so they may be undertreated. So I think the goal is we want to remove systems that make those biases exist. And so it's great when we have protocols that we follow, when we follow guidelines, and when we really stick to them for both men and for women, so that we make sure that we're not underdosing or not, for example, there was in a STEMI, which is when people are having acute heart attacks, and they were finding that women were often, the time difference in terms of treatment for men and women were different. And when you protocolized it and you said, we're going to do it this way, and it's the same for every single person, you reduce those disparities and you take away those disparities. So I think really making sure that people understand that, a blood pressure medication, if taken correctly, is as effective in a man as it is in a woman. And we just have to make sure that our patients, find a therapy that they can tolerate and that's agreeable with them. And I think sometimes medication side effects may make people more leery or more likely to come off medications, and people aren't willing to try and maybe don't do as much in patients. And so there's a lot of trial and error in finding something that works for the patients. It's a partnership in making sure that patients take the medications that they can tolerate and that work for them.
All right. Well, thank you so much. Really appreciate all that wonderful information. We did get some other questions from our audience. I'm going to ask those next, and we're almost at time. So any questions that we didn't get to, we'll be sure to answer them afterwards. So thank you for all the questions that you've been asking so far. So this one, I'll ask Dr. Case, because it's related to coronary microvascular dysfunction. This is from Ty. He said, we talked about chest pain being potentially related to coronary microvascular dysfunction. The test could show normal activity. What advice do you have on how someone like Ty can talk with their doctors about coronary microvascular dysfunction being a potential cause for that chest pain?
Yeah, that's a great question, Ty. Coronary microvascular dysfunction, we've known about it for a while, but it's certainly becoming more and more recognized and being a differential diagnosis for clinicians in trying to see if a patient has it or not. But there are certainly a lot of doctors out there who aren't thinking about coronary microvascular dysfunction, or might not have the knowledge base to fully understand that this is something that might be causing the symptoms of chest pain. It might be what their patient is suffering from. So, being your own advocate is definitely important. And it's definitely reasonable to bring it up to your primary care doctor or your cardiologist to say, hey, I heard about this. I'm concerned I might have it. And then they could evaluate things. And then if they don't have the capabilities to fully evaluate for coronary microvascular dysfunction, they can certainly refer to a center. In our area would be the MedStar health system, but there are other health systems within all the United States where there's centers of excellence for evaluating coronary microvascular dysfunction. There's also online resources. There's a coronary microvascular dysfunction network, along with a website that you can easily Google, and you can actually look up clinicians throughout the United States of providers who are performing this procedure to make the diagnosis.
All right, thank you so much. One more audience question. This one I'll send to Dr. Jean. It's related to hormones. This is from Gina. She asks, is hormone replacement therapy harmful to the heart?
It depends on the patient profile. And so that's why it's important to really sit down with your healthcare provider and go over your personal risk. Generally, a healthy woman in their 50s with otherwise very active, normal weight and low risk, they can tolerate hormonal replacement therapy without an excess risk for heart attack or stroke. But if you have high blood pressure, you're a smoker and have coronary disease, then the risk is higher. If you're older, which again tends to be correlated at times with just more underlying risk factors, then that can increase your risk for a heart attack and stroke. So it really does need to be individualized to the patient and with the focus on sort of balancing quality of life and risk.
All right, thank you so much. So those are all the questions that we have time for today. Before we wrap up, I did want to get some final thoughts from each of you before we wrap up. I'll start with Dr. Srichai. What key takeaway do you want to make sure our audience gets out of this discussion, or what other important information you want to make sure our audience knows about women and heart disease before we conclude our discussion?
I guess it would just be to be advocates for yourself and to make sure that you get checked out if there's anything that seems, if any of the things that we've talked about today seem like they could be applying to you, or even just figure out what your underlying risk for heart disease is, and to then bring that up at your meeting with your primary care, or and they might decide like, yeah, you do have some risk factors and maybe you should see a cardiologist. But just be an advocate for yourself and not ignore things that you think might not be quite right.
Great advice. Thank you so much. Dr. Case.
Yeah, no, I was going to say the same. I think Dr. Srichai nailed it. Don't ignore your symptoms. If you're having active acute symptoms, please get evaluated quickly. Even if it's not the classic chest pain that you might see on TV, like any type of abnormality, get evaluated. But even if you have subtle symptoms and you are not getting the answer that you believe is bothering you, and you just know something's going wrong, be your own advocate. Get evaluated, get a second opinion, get a third opinion. Do what you need to get fully evaluated, because they're your symptoms, and we can help you for sure.
Thank you, Dr. Case. Great advice. Dr. Ketlogetswe, what advice do you want to conclude with today?
I think I like to tell my patients that knowledge is power, right? Know your number. What's your blood pressure? What's your cholesterol level? Are your sugars high? I think knowing those numbers and having some information is really important, because then you can act on it. Many people come to us late. They have high blood pressure and just didn't know it because no one's checked their blood pressure. They haven't checked it in many years. So know your numbers and be proactive about trying to get in the best possible heart health you can.
Great advice as well. Thank you so much. And Dr. Jean, how about you?
Yes, knowing your numbers and all the things that were discussed definitely is important, and I do remind my patients that 80% of heart attacks and stroke can be prevented with a healthy lifestyle, but the numbers have been concerning in terms of us seeing higher death rates from heart attacks in that 35 to 54-year-old age group for women. And a lot of it is being driven by risk factors such as obesity, high blood pressure, and diabetes. So it's critical that we get the younger individuals plugged in, and to know that it really can impact them as well. And then sort of my other important, advocacy work that I do is around maternal health, and we're seeing the rising rates. And I think there's definitely an important area that we all can do better, is to get your blood pressure and your cholesterol, knowing your numbers before you get pregnant, because pre-conception counseling can be an important intervention to have a safe and healthy pregnancy and delivery. And so I hope everything that you guys have learned here today will be a good reminder about the importance of earlier check-in and intervention.
Great advice. Thank you so much. Thank you to our viewers for watching today. Thank you to our experts for being here today and sharing this wonderful information. If you would like to learn more about heart disease in women, and we also have a heart risk quiz that you can take, visit our website. We'll include a link to that in the comments. Thank you so much. Happy Heart Month. Take care of yourself. Thank you. Have a great day.
Thanks.